Health Education at Arizona Care Network. Today I have Dr. Mandeep Sahani, one of our preferred nephrologists who is with Desert Kidney Associate. Thank you so much for being here, Dr. Sahani. So nice to meet you.
My pleasure, Tannaz. Thank you for having me.
Thank you. Dr. Sahani, thank you so much for taking the time to go over chronic kidney disease. We wanted to share with our patients benefits of early referral and get some of your expertise regarding this matter. So you can go ahead and get started with what is chronic kidney disease or how early referral happens, all the good stuff that you'd like to talk about.
Fantastic. So thanks for that question. Chronic kidney disease is defined as the decrease in kidney function recorded as per labs. Usually it's the creatinine or the eGFR, otherwise estimated GFR, that is taken into account for 3 months, either continuously, that shows that there's a decrement in kidney function. Let me just close my door 1 second. Sorry, Tannaz, about the background. So as you're saying, chronic kidney disease is defined as decrease in kidney function that lasts for at least 3 months. Then how do you know that there's decrease in kidney function? By simple blood tests. Most of our patients get this blood test called basic metabolic panel, and also otherwise known as BMP. And the BMP has a creatinine, which is measured in the blood number, and also correlates with that is eGFR, estimated GFR. So this is less in the kidney function. If the creatinine is higher than 1.5 or sometimes 1.4, depending upon the labs, or if the eGFR is less than 60 for 3 months continuously, then it's defined as chronic kidney disease. And chronic kidney disease has various causes within this, as the causative effect for decreasing kidney function. But in our country, the most 2 common causes are diabetes and hypertension, and diabetes more often than hypertension causes chronic kidney disease. It is estimated that at least in the adult population, 1 in 7 have CKD or chronic kidney disease, and patients and people above 65, so that's the medical eligible age, slightly high, it's about 38 to 40% of patients or members have CKD. Now that's a staggering number. The spend or how expensive this disease is also significant. I mean, both dialysis and chronic kidney disease, the total spend is about $120 billion a year. It is about 35 billion in for dialysis, and twice, a little more than twice, in CKD. So what is our opportunity here? Our opportunity here is perhaps to recognize our patients with CKD. And we know statistically that about 90% of our patients who have CKD don't know that they have CKD. And very often, the only time that they get found out is when they have to start on dialysis, which we sometimes refer colloquially as crash and burn. They crash in a hospital, and the only thing you can offer them now is dialysis. So there is the opportunity of educating our patients is lost when they start dialysis as late. The opportunity of slowing down CKD, progressing to dialysis, is lost if we see them that late. And of course, the burdens of illness that CKD brings. So CKD in itself is an independent risk factor for cardiovascular disease. That itself then adds an additional comorbidity and additional spend for our Medicare dollars. So hence the importance of recognizing CKD at an early stage with the intent that once you've recognized this, what do you do? What are your next steps? Is number 1, education for the patient on how they can empower themselves and through taking the right medications at the right time, knowledge base of the disease process and therefore help slow down the progression of CKD to dialysis. So then the next question is, how do you define early detection? And then the next step is, what do you do once you've defined early detection? And when do you refer to a nephrologist? I think just like anything else, no one person can do everything. It takes a team to climb a mountain. So it's that teamwork and collaboration between our patient's primary care physician and the nephrologist that's really becomes really important. There's no hard and fast rule as when we should recommend from a primary care perspective, but I think what is recommended is that at least when they're CKD stage 4, a patient should see a nephrologist. I'm of the thought that perhaps a little sooner, a little further upstream, whether it's CKD 3A or 3B, that's debatable, but definitely in the latter part of CKD 3, which is maybe stage 3B, is when we should have our patients see a nephrologist. Now, what does that do then for the patient? It builds that trust and relationship with that nephrologist at an early stage. And I've seen it very often if I'm seeing the patient for the first time and I've got to break the bad news that, okay, dialysis is the only option. It's not taken well. Often the reaction I get is, but doc, I feel fine. Why are you asking me to start dialysis? The numbers speak for themselves. So if the nephrologist is involved in the early stages, that trust factor and that collaborative work that he or she can do with the respective primary care physician definitely helps decrease the disease burden and definitely helps decrease the progression of CKD. So to make a clear distinction, CKD stage 4, most definitely, but it's better to have our patients be seen or referred to a nephrologist, either 3A or 3B.
So, Dr. Sahani, I have a question for you. So, you mentioned that in this country, the people that are at most risk are people that have diabetes and high blood pressure. When a patient goes to their PCP, primary care physician, and they have diabetes and high blood pressure, is this a routine exam that they do, that they check their kidneys, or do they have to ask for it?
So it's actually a routine test, a blood test that's done even when the first time you would see your primary care doctor. A urine test is done, a CBC and a BMP is done. It's in the BMP that will detect the presence or absence of kidney disease and also in the urine. But you raise a very good point. For patients who have diabetes, it's important for them to be empowered with the knowledge that, hey, I'm at risk of progressing or even getting CKD, then I should be asking the right questions to my primary care doc. All right, I have diabetes. Am I at risk for CKD? If so, number one, how do I find out that I have risk for CKD? And then how do I quantify my risk? As in, what is the likelihood of me progressing in this stage? And what measures can I do to prevent it or slow it down? And, when do you think I should see a specialist?
Gotcha. And what are some of the health consequences of chronic kidney disease? I know that you mentioned that there are rarely symptoms and people tend to crash into dialysis, and we tend to catch patients at a later stage. But if they do show any symptoms or any health consequences, what are those, and what should patients look for?
Right, excellent question. So unfortunately, the symptoms are non-specific, like fatigue, more than usual, and the fatigue may be gradual in onset, maybe insidious, so it's difficult to pick up whether it's happening over a long period of time. May go unnoticed. It's loss of appetite. It's some of my patients complain of aversion to meat or otherwise protein. And some of them also do distinctly complain of a particular metallic taste. So these symptoms are non-specific to any diagnosis. Hence, it's difficult to tease out if it is indeed from the worsening of kidney disease, or could it be something else? And with that, then you correlate that with the patient's labs, the blood tests, and the urine test to see, yes, this could more than likely be from the effects of decreased kidney functions, because now the body's finding it difficult to release all the toxins through the kidneys, and hence, an alternate way, such as dialysis or transplant, has to be considered so that the body can get rid of the toxins that way. That's why it becomes imperative that if a patient suffers from diabetes, it's important to ask, has it affected my kidneys? Am I at risk? And if there's progression, then how do I tell that I'm getting worse? So those are the symptoms that my patients usually complain about.
Wonderful. Thank you so much for that. And how often do you recommend patients in early detection or early stages of kidney disease? How often do you recommend patients getting checked, like blood work and being seen, whether it's getting, kidney function tests done, things of that nature?
So I think the protocol, if in early stages, whatever their protocol is set by their respective primary care physician, should be followed. But if the primary care physician were to include a nephrologist at an early stage, then I can suggest, how often that nephrologist can see that patient. So CKD stage 1, perhaps just once a year, the nephrologist should see the patient, but follow up with labs that not necessarily the nephrologist has to do, but the PCP can send over those labs. So we can have, additional set of eyes on the patient by looking at if there's a progression or worsening of the labs. If it's the later stages of kidney disease, maybe a little more often, coming to then stage 5, then at least once a month visit with the nephrologist, because now you're close to on dialysis, and you don't want to miss the opportunity for a timely start and an optimal start to dialysis. And by that I mean is, if one's going to start dialysis, not start with a catheter in the chest, which is a foreign body, but with a fistula in the arm, and perhaps not in a hospital setting, but in an outpatient setting. So as the disease progresses, the frequency that they should see a nephrologist increases. But at any given time is that comprehensive collaborative approach with the primary care physician, the patient being the center, and the nephrologist and other ancillary providers, working for the best of the care of the patient.
So my understanding from all the wonderful information that you're sharing with us is that it for patients that are progressing to higher stages of kidney disease, early referrals and early detection helps with planning and predictability for the patient and allows that relationship to be built to plan ahead of time and not just have to make a decision over like a day.
Absolutely right. And then you've probably heard of the adage that if you're going to predict often, right? So it's better than to have a follow-up visit with your nephrologist in the latter stages, so that nothing is missed. And of course, emphasis is on the collaboration between the primary care doctor. And what do I mean by that collaboration? Is of course exchanging timely notes, exchanging timely labs. So there is a decrease in repetition of doing the blood work and the urine work, and the patients are not burdened to go to the lab ever so often. That I think there's enough literature out there that when a team comes together to take care of that patient, the glide path or the transition to dialysis becomes smoother. The patient is well informed, well educated. He knows what to expect, doesn't run into any surprises, and the overall morbidity decreases by decreased hospitalizations, timely use of the right medications, compliance to medications, and adherence to dialysis as well.
Wonderful. And Dr. Sahani, what is the blood pressure cutoff that you recommend for patients that have high blood pressure or they have diabetes to kind of stay within that range to not put too much pressure on their kidneys?
So if they have kidney disease with or without proteinuria, it's 125/75, has to be regulated using ACE inhibitors, and now the newer medications, Farxiga, and the like, should also be started at an early stage in CKD, as these medications have shown independently to slow down the progression of CKD towards dialysis. So not only blood pressure control, of course, there's got to be optimal sugar control, optimal diet, trigger as in triggered for their disease state, whether diabetic, hypertensive, or cardiovascular issues that the patients may be having. I think that a whole comprehensive approach is warranted. So it's not difficult to diagnose CKD. It's a very objective measure. So it's either you have it or you don't. The issue becomes in creating a robust program with the help of the primary care physician on how you can, literally wrap your arms around that patient. Throughout the journey, if they do end up on dialysis, they're going to be seeing the nephrologist at least 4 times a month if they're on in-center dialysis, and definitely once a month when they're on at-home dialysis. So establishing that relationship at an early stage becomes, and being part of that programmatic approach becomes very important.
Absolutely. And Dr. Sahani, I've worked in my career, I've worked with a lot of patients with kidney disease as a clinical pharmacist, and there's a lot of confusion regarding, the potassium imbalance and all those other things that, you often hear. So if my potassium's high, or I have early stage chronic kidney disease, my potassium's not high yet, can I eat bananas? Can I do this? Can I do that? Can you clarify that a little bit for our patients, just so they know, reduce that confusion about potassium and all the other things that go hand in hand with kidney disease?
Sure, absolutely. So as in the later stages of kidney disease, monitoring potassium level becomes really important. And potassium is part of the basic metabolic panel. So every time that's done, you get a whole set of electrolytes, including the potassium as well. Now, the kidney is mostly responsible for getting rid of the potassium. So if the kidneys don't function, there's a good chance if the intake of potassium is high through potassium-rich foods like tomatoes, potatoes, oranges, bananas, nuts, avocados, then because the kidney can't excrete that, it stays in the bloodstream, and they can cause, cardiovascular effects and also muscular effects. The therapeutic range that the potassium has to be maintained is quite narrow. Hence, the importance of having a diet low in potassium becomes really, really important. So we often stress, as part of the comprehensive approach to our patients, is to watch what they eat, avoid potassium-rich foods, and if they have to do it, make sure that they recognize what the exact quantity or limited amount of potassium that is recommended by either the nephrologist or a registered dietitian. They should, try their best to comply with. There's new technology on the horizon, just like we have now continuous glucose monitoring, or CGMs. There is a push to make a continuous potassium monitoring device, which will be just like the CGM, and we hope that allows, just like a patient can know in real time what his or her sugar level is and can adjust the anti-diabetic medication. In real time, we can know what the potassium level is and can either adjust to diet, or, as you know, there are newer medications that can lower potassium levels. So barring that inavailability of the technology yet, it's best to have a good dietary program that you restrict your potassium intake, and also be careful of certain medications that might raise your potassium, and monitor your BMP, which tells you what your potassium level is, as frequently as recommended by a nephrologist or a primary care physician.
It's wonderful. I didn't know they were coming out with a monitor like that, so that's going to be really helpful.
Yeah, there's a company out of Canada that's doing that. The company's called Proton Intel, which they're trying to make that just a patch, just like you have with the CGM monitors. Yeah.
That's really nice. That's wonderful. Well, I know you're very busy. You've given us a lot of information. Just to wrap it up, what if you could give our patients just a few takeaway points for this matter, what would it be?
Thank you. So important to know that even though the prevalence of CKD is that high, like 1 in 7 adults or 38% of seniors above 65 have CKD, not everybody ends up on dialysis. And the people who don't end up on dialysis are the ones who there's early detection. They have, understood through education what the disease process is, what the disease burden is, and how they can, with the help of their healthcare providers, influence and decrease the burden and hence the progression of CKD. And we're lucky in this. In the last few years, we have multiple medications that have come out that help decrease CKD progression. So I think with all combining everything, perhaps early referral, if the primary care physician is comfortable working, in a team-based effort, definitely education for the patient, both dietary and disease burden-wise, has clearly shown to decrease the progression of CKD.
Wonderful. Thank you so much,
That's
Dr. Sahani. I really appreciate your time and
My
going
pleasure.
over all this information. Our patients can send in questions. So once they do send in questions, I'll refer them to you and we'll have a response for them whenever you have time. But as far as today, thank you again for being here and I appreciate your time.
All right, fantastic. Thank you so much. Okay, take it, Tannaz.